I'm a plastic and reconstructive surgeon. I'm an MD, and I was trained in general surgery. I served as a general surgeon in the Navy, and then the Navy sent me off to become a plastic and reconstructive surgeon. Gender identity disorder it's a person who is suffering. The suffering is real. They're suffering over, typically it's a wounding event that's happened in childhood, right? They don't want to look at that wound. They'd rather come up with an explanation for why they feel so bad, an explanation they can live with, right? It's my nose. It's my gendered appearance. It's the presence of breasts. It's the presence of male genitalia, whatever it may be, but it's the same problem. Obsessive thought leads to compulsive behavior. All such scars, no matter how good a plastic surgeon you are, you have scar effects that can stricture the urethra. So you can very often wind up with urinary obstructions that require further surgery and urinary leakage that essentially causes a chronic repetitious soiling of the patient because they can't control their urine any longer.
Well, Dr. Patrick Lappert, could you maybe start off by telling people who you are and why we might be interested? I'm really looking forward to this conversation. I think it's really important information you've got to tell us. So if you could just tell us where you're coming from in this world.
All right. Well, thank you for the invitation, Stella, and I've been looking forward to this for some time. I'm a plastic and reconstructive surgeon. I'm an MD, and I was trained in general surgery. I served as a general surgeon in the Navy, and then the Navy sent me off to become a reconstructive surgeon, plastic and reconstructive surgeon. So I got my second residency and board certification, and then served as a reconstructive surgeon in the Navy for a number of years, and then 20 years more as a civilian private practice plastic and reconstructive surgeon.
And you have seen, or you have knowledge around medical transition and surgery that I think is very important that people know about, because I think so many people, they aren't aware of the realities of surgery. They aren't aware of the complications, the complication rates, the kind of issues. I think people are very light about going into surgery these days, especially because it's identity driven and they believe it's some sort of life-saving care.
Right. Well, I think perhaps the most important issue to begin with is one that's a very important issue for plastic surgeons in particular. And that has to do with the distinctions between reconstructive surgery and cosmetic surgery. So this is a very important distinction to make at the beginning. So and the reason this is important is because the proponents of gender affirmation surgery present it as reconstructive surgery. All of their documents speak of it as reconstructive surgery. So let's begin with a definition about what that means. Reconstructive surgery is the restoration of form and function that has been lost due to trauma, in utero accident, perhaps genetic accident or inherited traits, the treatment of cancer, trauma, that sort of thing. There's a loss, there's a definable loss or poverty that the patient experiences. And what the reconstructive surgeon seeks to do is to restore form and function so that you can have the fullness of human life to whatever degree you're capable. And that's reconstructive surgery. Now, contrasting that with cosmetic surgery doesn't begin with a defined defect or poverty or loss that the patient is experiencing. It begins with a feeling that the patient has in their subjective life. They feel that there's something about their appearance that causes them distress. That appearance may be within the range of normal human variation, but they may feel that it's a burden to them. So it begins in their subjective life. Say, for example, they feel their nose is too big, or they feel that women aren't attracted to me because of my hairline or because of the prominence of my ears, or whatever it may be. Sometimes they're small things, sometimes they're large. But whenever a patient comes to a plastic surgeon seeking cosmetic remedy, one of the key things the surgeon must do is understand their motivations and their expectations. Why are they coming to me about this? Why has it become something important to them? And furthermore, what do they expect to gain from modification of their appearance? This is a very central issue in plastic surgery. because there's a subcategory of patients who present to us plastic surgeons seeking a physical remedy for an interior subjective emotional disturbance that they're experiencing. Sometimes they're minor and sometimes they're very grave. I can't tell you how many times I've been consulted by women seeking breast augmentation, for example, who, when you're going through the whole process of giving them an understanding what the surgery entails and what the expectations of result might be, they'll start to confess to you that their expectations are very high. And they may say something to you like, I know that if my breasts look younger, my husband wouldn't leave me. Okay, so that is an example. That's not an uncommon example. A person experiencing some psychological, emotional distress in their life that they think will be remedied by an alteration in their appearance. Okay, it can be trivial, it can be grave. The more obvious examples of that is a condition that we call body dysmorphic disorder, where this is essentially what I've just described to you, that the patient has a grave interior wound that they don't want to look at. They don't want to look at what has harmed them, what is causing their distress. They would rather explain it on the basis of their appearance. It's a safer thing to do because it doesn't require them to examine perhaps the wounding event that's caused them such distress. So they'll ascribe it to their appearance and they'll ask you to change their appearance. As a plastic surgeon, the ethics of plastic surgery demands that if I know that the patient has come to me with this condition of body dysmorphic disorder, it is malpractice to offer them surgery. It's as simple as that. Why? Because the patient is...
Why? But I didn't know that that's down. That's an actual guideline that surgeons can't overthrow.
Well, yeah, and so it's by degrees, sometimes trivial and sometimes grave. So, for example, a young boy who's experiencing difficulties, he's in late adolescence and he's got prominent ears and he's not fitting in with people at school, and he ascribes his isolation to his ears. Well, if I tell him, yeah, I'm going to fix your ears and your life will be well, that's a disservice to the patient. It's a moneymaker for the surgeon. I mean, you can see people in the public light, entertainers especially, who are constantly modifying their appearance, seeking to restore something they feel they've lost. So that's a very important distinction to make. And I make it at the beginning because it must be understood that what is today called gender distress or gender discordance or gender identity disorder or whatever term you may apply to it, it's a subcategory of an obsessive-compulsive disorder, which is what body dysmorphic disorder is. The patient is obsessing about their sorrow, right? And it leads them to compulsive behaviors about their appearance to others, compulsion about the appearance of their nose, going to a plastic surgeon for a consultation about their nose, constantly thinking about it, an obsessive thought that leads them to the compulsive behavior. What you don't want to do as a surgeon is to put yourself in the middle of the compulsive behavior and make visits to your practice and visits to the operating room part of that cycle of obsessive compulsive disorder. That's a great disservice to the patient. And it's unethical for the surgeon to do such a thing. Well, this is precisely what gender identity disorder is. It's a person who is suffering. The suffering is real. They're suffering over, typically it's a wounding event that's happened in childhood, right? They don't want to look at that wound. They'd rather come up with an explanation for why they feel so bad, an explanation they can live with, right? It's my nose. It's my gendered appearance. It's the presence of breasts. It's the presence of male genitalia, whatever it may be, but it's the same problem. Obsessive thought leads to compulsive behavior. The compulsive behavior may be binding their breasts. It may be tucking their genitalia and dressing as a woman. Whatever it is, they're seeking a remedy for their anxiety, right? And this is at the heart of what gender affirmation care is. Gender affirmation care is essentially a professionally crafted obsessive compulsive process, right? Where the doctor is agreeing with the obsessive thought. The doctor says, well, the reason you're constantly thinking about these things is because you, in fact, are not a boy, you're a girl, right? The doctor is affirming a delusional idea because that's at the heart of an obsessive compulsive disorder. The obsessive thought is a delusional idea, right? And what does it mean to be a delusional idea? It means that it's not accessible to rational argumentation, right? It's firmly held by the patient. And the third criteria is it's impossible. That's what a delusional idea is. It's firmly held, a fixed, firm belief, right? It's not accessible to logical argumentation, and it's impossible. This is the case with gender affirmation. It's impossible that a boy can be born in a girl's body, but you can't talk them out of it, and it's held fixedly and firmly. And what the proponents of gender affirmation care will insist upon is that fixed, firm belief is actually a diagnostic criteria. And they'll say things like, well, the child is insistent, the child is consistent, and the child is persistent. And that's the diagnostic criteria of gender discordance, right? Well, those are just three ways of saying a fixed, firm belief. It's right. So essentially, that's what we're dealing with gender affirmation care. So that's how we should understand it broadly in terms of where it stands in the world of a plastic surgeon.
So, doctor, if I base myself just on what you just described, I would think that there would be no plastic surgeons working on gender affirmative medicine, because there's these fairly clear ethical guidelines and principles that you've laid out, and yet we're seeing quite the opposite. I think your field has been very complicit. Not
Yes,
you,
sir.
of course, but
Yeah, well, no, it's a source of great shame for me as a plastic surgeon. But the other specialties involved are doing precisely the same thing. It is unethical, for example, to give puberty blockade and cross-sex hormones, which is experimental, and to tell parents and to have them sign consent forms telling parents that this is actually a proven therapy or that it's the standard of care. This is a gross misrepresentation of where the science is, and it's a hugely unethical way to obtain consent. And we can drill down into the details, but you'll see that all of these treatments that are being offered are experimental in nature, but they're obtaining consent for them by telling parents and children that this is proven treatment, that it's a standard of care. And we should talk in some detail about what it means to claim a standard of care and what the standard of scientific evidence ought to be.
I'd like to, just before we do go into the standards of care and what is a standard of care, I know the plastic surgeons in America, they did come out. They're the only people who've come out. Would you just tell our listeners a little bit about that they have come out with some kind of integrity around gender dysphoria? GenSpec's Bigger Picture Conference Series returns for its fourth landmark international event this September, the 27th and 28th, Saturday and Sunday, in Albuquerque in New Mexico. At this time, we're not just analysing problems, we're shaping the solution. We're looking for a way forward, and we've chosen the best speakers, the best leading thinkers of our generation to discuss how we can move the dial. With the theme Live Not by Lies, Conversation for a Culture in Crisis, this year's conference tackles one of the most urgent challenges of our time: how to speak truth in the face of conformity, confusion, and institutional pressure. As the politicisation of sex and gender continues to divide societies and derail thoughtful discourse and destroy loving and engaged families, this groundbreaking counterpoint to WPATH brings together the world's leading thinkers, clinicians, policymakers, lawyers, politicians, and psychologists to forge a path that is ethical, evidence-based, and grounded in reality. Abigail Schreier will expose the hidden consequences of bad therapy. Dr. Lisa Littmer will present her latest groundbreaking research. Lionel Shriver lays bare how society's fixation on trans identity distorts truth and undermines fundamental freedoms. Peter Boghossian will present Truth Over Lies, Bold Conversations in a Fractured Culture. Dr. Patrick Lappert will discuss the impact of trans surgery, while Dr. Quinton van Meter will discuss the impact of hormones. Following defining events in Killarney, Ireland, in Denver, Colorado, in Lisbon, Portugal, we're now coming to Albuquerque in New Mexico. This is more than just a conference, it's a call to action. Join us for 2 days of unflinching honesty, rigorous evidence, and solution-focused collaboration. It's time to move the dial, and you need to be in the room. Visit genspec.org to secure your place.
Well, yes, it's late. It's come out late, and it's been somewhat tepid. Essentially, what the American Society of Plastic Surgery said was that the W path, talking about broad consensus in all areas of gender affirmation care, the plastic surgeons came out and said, you can't claim broad consensus because we've never said publicly that this is a standard of care. That's what they said. They didn't come out and say, well, this is a terrible thing to do to children. They just said, oh, no, we haven't spoken about this at all. And you cannot claim unanimity or a consensus in the medical world because we have given no such affirmation or consensus. So they haven't come right up. But I can also tell you that I've been to plastic surgery meetings over the last 10 years where, programs are being presented, speakers, multidisciplinary presenters and stuff talking about how to include or how to bring in affirmation care into your practice, how to make it a success, how to manipulate the insurance companies, how to manipulate local politicians so that you can get funding for offering these services to children.
Oh my God.
Yeah. So while they haven't officially affirmed that affirmation care is valid, they've nonetheless given a venue for the presentation of this idea of affirmation care in their meetings. I went to a California Society of Plastic Surgery meeting some years back where the entirety of the Sunday morning was dedicated to how to bring affirmation surgery into your plastic surgery practice and make good money at it. So it's a shameful thing.
That brings me on to, I have often thought about plastic surgeons. It must be almost polar opposites. Some people must be very, very moral because they're in it to kind of really, like people who've had car accidents and fires, and you're really doing something extraordinary, life-changing. Like plastic surgery for the right people is such a beautiful thing, really. And then that, like, we've all seen the crazy TV programs where it looks like people with body dysmorphic disorder have just got increasingly massive breasts and things like that. So there must be a split in these conferences where there's the ethical crowd at one table and the money mad crowd at the other table. And do you hang out with each other?
We do tend to hang out with each other, because most plastic surgeons are in the camp of wanting to do meaningful work on behalf of people. And there's a whole subset of people who go into plastic surgery because you can make a great living doing it. And so when you go to these conferences, there are vendors there selling all kinds of products and techniques and things that you can apply to your cosmetic practice. And there's huge money in it. And then there'll be us, primarily reconstructive surgeons, circulating around looking for new ways to help people with their reconstructive needs. And you have to sort of circulate through the sea of very well-dressed people looking to make a lot of money.
So tell us about the standards of care. What is the standard of care? Yeah.
Well, when you're talking about offering care to patients, it begins with what is the standard of diagnosis, for example? How do you make a diagnosis? Well, in reconstructive surgery, the diagnosis is fairly straightforward. You define the defect, you characterize what is needed to restore form and function, and then you seek means for accomplishing that, whether it be tissue transfer or grafts or whatever it may be. And so within reconstructive surgery, for example, if I had a woman who had lost her breast from cancer treatment, there are a variety of ways to not only treat the cancer, but also to reconstruct the defect. So at every step in the woman's care, she's being offered alternatives of care, right? So for example, the removal of a lump and radiation treatment might be one mode of treatment for her cancer. Another one might be complete removal of the breast. The patient will be presented with those options and say, well, so for example, lumpectomy and radiation has this success rate in your stage of breast cancer, whereas mastectomy may be the other. And the patient has the option, you present it as a treatment options to the patient, and you present them with evidence that allows them to give an informed consent, right? So what is that evidence? That's the important part of this. What is the evidence, and how did we get that evidence? It should be remembered that in the history of medicine, there have been many, many scandalous treatment modalities that have been presented as the standard of care. So for a time, frontal lobotomy was considered a standard of care. Thank God it wasn't considered a standard of care for long, but nonetheless, it was presented as an option of care to persons suffering with major depression, medication versus lobotomy, whatever it may be. That's an example where but that's a scandalous example because lobotomy had zero scientific evidence to support it. It only had an expert opinion. In fact, the expert opinion of one particular practitioner that everybody bought into. So because of these scandals like that and others that I could go into with you, like thalidomide and, all kinds of examples that are out there, some years back, the medical and surgical specialties resolved that henceforth we will be evidence-based. And so, for example, in the American Society of Plastic Surgery, our analysis of what's needed for evidence-based surgery resulted in a very simple table that ranks scientific evidence from 1 to 5, 1 being the most solid scientific evidence and 5 being the least reliable form of scientific evidence. As it happens, the lowest form of scientific evidence available is an expert opinion, right? Which is a remarkable thing to hear from a guy who's here giving you an expert opinion. But nonetheless, it is the case that the weakest form of support for any therapy is an expert opinion. Now, if that expert can marshal better information, then his expert opinion is now informed by perhaps level 4, level 3, level 2 evidence. What does that mean? Well, level 5 evidence is if I was to come to you and say, hey, I did 5 gender affirmation chest surgeries on natal females, and here's my results, okay? That's single provider, me, single center, my hospital, right? And a very small sample size with probably massive selection bias. So that's still level 5. So now if I give a presentation and say, hey, I'm an expert and I've done these cases and here's what I find, and therefore I recommend mastectomy on adolescent girls. That's level 5 evidence. If, on the other hand, I had 4 other practitioners in town operating in 2 different hospitals, and we could collate all of our data together to a larger sample size, perhaps I would reach level 4. But there's studies like that have tremendous sample bias, selection bias. What kind of patients does this doctor select? What kind of patients come to this doctor? What kind of patients agree to have their information examined? Those are all biases that keep that at level 4, level 5 evidence. The important thing to remember is that if that's all you have, if all you have is level 4 or level 5 evidence, then when you're offering that procedure to the patient, you must tell them that this is experimental. It's experimental care because I don't know what the long-term result is. I don't have a cohort of control patients. I haven't followed them long-term, right? So essentially, this is what we have in the world of gender affirmation care. Level 4 and level 5 evidence only, which means it's a huge public experiment that is not being regulated. Human experimentation is a very serious matter, right? The Nuremberg trials had a lot to say about that, and that we carry that with us to this day. So, but what's happening is this is being presented not as experimental care, it's being presented as a standard of care. All right, what is a standard of care? A standard of care means that your evidence is so compelling, it's so airtight, that to do anything other than this recommended care would hazard the patient's welfare, right? That to do anything other than the standard of care, you're likely to have to answer for it if things go bad in a court of law, perhaps, tort law, whatever it may be. What is more typical is not that the parents or the patient are saying, this is the standard of care. They're offered a treatment guideline, alternatives of care, like I talked to you about with breast cancer. You come to the patient, you come to the parents, and you say, here are the options of care. This is the success rate with this one. This is the long-term success rate with that one. You have particular issues in your life that might guide your decision. I don't want to be without my breast, whatever it may be. The patient decides based on informed consent. So treatment guidelines is typically what most expert organizations run on, right? So, for example, in the Endocrine Society or general surgery, if you have a patient with a thyroid nodule, then there are standards of care for making the diagnosis. How are we going to make the diagnosis? How are we going to confirm that this is thyroid cancer? And then having made the diagnosis, we offer options of care: lobectomy, thyroidectomy, radiation, radionuclide therapy, whatever it may be. This is how consent is supposed to be obtained based on the quality of scientific evidence. Well, let's look at the example that we're really dealing with here right now with the WPATH standards of care, the World Professional Association of Transgender Health Standards of Care version 8. Well, when they claim standards of care on the cover of the document, they call it the standards of care. But on the first page of that document, they say, oh, by the way, this is not a standard of care. This is a treatment guideline, right? Why? Because when you read into the text, you see that at every step, nobody says emphatically mastectomy. Nobody says emphatically puberty blockade. Nobody says emphatically anything. They say, well, you might do mastectomy at 15, or you might do it at 13. It's kind of up to you. Then they present it as a treatment guideline only, not standard of care. The problem is, as I elucidated before, a standard of care means you're describing alternatives of care to the patient. And the World Professional Association of Transgender Care does no such thing. They say it's our way or hazarding the life of your child. And that is not consent. That's consent under duress. And it's based on experimental levels of information, based on a treatment model that is experimental in nature. But consent is being obtained while the parents are being told that this is a standard of care. This is a terrible miscarriage of ethics. And they're going to answer for that.
Yeah, that was my next question was, how long will the experiment go on before we say, well, we have results and we kind of know some things about this way of treating gender dysphoria, and it's certainly not the best or even a true treatment of it at all.
Yeah, and so in some areas, so for example, in Great Britain, in England, in the National Health Services, they did precisely that. They looked at the levels of evidence at the Tavistock Portman Institute, and Hilary Cass came back and said, yeah, we're going to stop doing this. And anybody who gets such treatment now will be highly selected, and it will be presented as experimental. It's an experimental protocol now in the National Health Services, which is where it should have been all along. But then you can get into the details about, is it a worthy experiment? Because the harms are known and grave, and the benefits are uncertain at best. Right. But in places like the Tavistock Portman Institute or the Karolinska Institute, they've looked at it and said, yeah, we're going to stop this right now. And of course, they benefit from their methods of record keeping that the American medical organizations do not have. Long-term longitudinal examination of all patients, comparison groups. What do we find? And this, of course, is what the Karolinska Institute, in looking at the long-term outcomes of full transition, they found that it has no benefit in terms of what they claim is the single biggest reason for doing the procedures, which is avoidance of suicide. Right? Your child, do you want a live son or a dead daughter? That kind of talk, right? Well, that not only hasn't been proven, but what you find is the long-term results that the Swedish study shows us is that in natal females seeking to present as males, they're 40 times more likely to kill themselves, right? Yeah. So the evidence of harm is overwhelming right now, and the evidence of benefit is non-existent. It's basically expert opinions dressed up as a standard of care.
So like number 5 and number 4, 5 was expert opinion, 4 was expert opinion on your mates, as far as I could.
Well, yeah. So it's a little better than that. So for example, if you have a little bit more airtight patient selection, and you might have a cohort to compare with, you might reach level 4 evidence. But here's
3 and 2 and 1.
Okay, so level 3 evidence is where you have a longitudinal study, long-term study with a quality cohort to compare with. So, for example, the Jenna article that came out of Sweden, they have a medical record keeping there that is a lifelong thing. They track their patients from in utero into the grave. And so you can query that database and you can have a comparison cohort. You can age and sex match controls for every one of those patients that's in the study that had affirmation care. And this is
we'll put this in the notes, but that study shows that the long-term outcomes for people who medically transition are appalling. They're more likely to go to prison, more likely to be, signed into a psychiatric hospital, much more likely to die by suicide. Long-term outcomes, and this is in Sweden, which is a very progressive country. It doesn't have good outcomes.
Yeah, you cannot blame the findings of the Swedish study on transphobia. We're talking about Sweden, for goodness sakes.
What is 2 and 1? So that I've got the number 3 is longitudinal.
Yeah. So when you get into 2 and 1, you're getting into studies that can be blinded. So, for example, pharmacologic studies where you can have placebo control, things like that. The problem is that you can't do placebo controlled surgical studies because it's unethical to do sham surgery.
Yeah.
So you can never get a surgical study up to level 2. But if you do a systematic review, which is what the CAST study is, and there are others in the literature that I'm sure that you're very familiar with, systematic reviews are essentially a level 3 and kind of above, very solid. So, for example, a study was done by Dr. Tolstrup a few years ago, looking at the world literature on chest masculinization surgery on self-diagnosed trans males, women seeking to present as men. So he queried the entire world literature on chest masculinization. He found 849 articles. All right, so this is a systematic review, 849 articles. Of those 849 articles, only 5% could be included in the study because of basic problems with the publication, basic problems with the study, basic problems with the reporting, language, whatever it may be. As he drilled down into the quality of evidence, it boiled down to, I think, 1.8% of all the papers presented, among which, I think it was a total of like 25 papers out of 850, out of which you could not do a meta-analysis, meaning you couldn't collate all of the information in these few studies to come up with a better result because they didn't even agree on language. They could not be compared. Even the test instruments, the measuring instruments, the language, all of it. Essentially, so what that means is that the net world literature on chest masculinization is zero. All you have there is expert opinions from all over the world.
Oh my God.
Isn't it so bizarre that we can call a double mastectomy chest masculinization?
Correct.
It just reminds me that all of the vocabulary around this issue is a misnomer, and it makes it hard to communicate in ways that will be understood and simultaneously truthful. Because, I know women who've gotten double mastectomies and they didn't call it chest masculinization.
I've been involved in a number of legal cases at the state and federal level, and I get to read the expert opinions of my adversaries in the courtroom, other plastic surgeons who present these sorts of things, and the manipulation of language is kind of their stock in trade, as we talked about earlier. Yeah. They'll talk about a gender affirmation surgery as reconstructive. And they'll insist that you're doing something reconstructive when in fact you're doing something mutilating. But the manipulation of language is an essential part of the whole ideology, because the ideology itself is a manipulation of the language about what the nature of the human person, the nature of our sex self. All of it is a manipulation of language.
What do they think they're reconstructing? I can't even follow their train of thought.
Well,
no. This is like plastic surgery 1A. What is reconstruction? Well, reconstruction is the restoration of form and function. But the problem is you'll have an expert there testifying that it's reconstructive surgery, and he's got academic credentials and many publications, and he even writes the board questions for board certification in plastic surgery. And he'll insist, if you want to pass his test, that you answer it his way. So the pressure on young professionals is extravagant. Yeah.
Our position in GenSpect, and I'm interested on your response to this. Our position in GenSpect is that, medical transition is not healthcare. It's not healthcare. It's extreme body modification, and
Right.
therefore it shouldn't be out of the public purse. It shouldn't be in hospitals, and if it's going to be anywhere, it should be in body modification clinics. I.e., this would be kind of cosmetic surgery. It would be calling
Exactly.
it. Yeah. What do you think of that? Because I've heard lawyers who I've ran it by, and they're like, yeah, but then there'll be no constraints on this. It will just go insane entirely. And I'm like, be at least honest or
Oh no,
something.
there are constraints on body modification. There are ethical constraints. There, licensing in your state. If you have a series of because when you do things like that to people, because the motivation is based in a delusion, this is one of the dangers of doing cosmetic surgery on body dysmorphic patients, is that it helps for a while. This is characteristic of these interventions, is that it helps for a while, but then what happens is it no longer helps, because the interior wound that's causing this manifestation has not been addressed. So for a while, they'll feel better. Why? Because affirmation messaging helps people who are in distress.
Mm-hmm.
Even when you lie to them, if you give them an affirmation message, they'll feel better for a while. And then they don't feel better because the wound is still there. And this is characteristic. So for example, in plastic surgery, a very common thing to see is a man comes in for rhinoplasty. And as soon as a man is scheduled for rhinoplasty consultation, the red flag's already up. Why? Because it is a known problem that men seeking to change their nose are struggling with such a problem as this. And you may make their, ethnic nose look very elegant, movie star quality rhinoplasty, but eventually they'll come back and say you did the wrong operation.
Oh, really?
Yeah. A friend of mine, Mark Gorney, God rest his soul, a plastic surgeon, ENT plastic surgeon, he started an insurance company for doctors, and it's called the Doctors Company. And because of his business, he looked into things that doctors are likely to suffer from, work burnout, whatever it may be. And what he discovered was that there was inordinate overrepresentation of violence against plastic surgeons by men who have had rhinoplasties.
Wow.
Murders, right? Mark Gorney, I remember sitting in his presentation about that. Seriously. So, but the reason I give you that glaring example is it must be understood that when you do body modification on a person who's suffering from body dysmorphic disorder, it only helps for a while, but eventually you're likely to wind up in court where they're seeking redress for a surgery that you think was the greatest surgery ever, but the patient is still claiming that this is a horror, and they'll sue you, So, and then state licensing boards, if they see you're getting all kinds of lawsuits for doing all kinds of bizarre things, you'll probably lose your license. You'll probably lose membership in professional societies. You'll probably lose malpractice coverage. So there are constraints on body modification, but to your point, we must understand from beginning to end that whether you're talking about the hormonal manipulation of the child or the surgical manipulation of the adolescent or the young adult, this is all cosmetic, because it begins in the subjective life of the patient. And if you read the articles that support the use of these remedies, they're all what we call life satisfaction surveys, right? Do you feel better? Yeah, I feel better. Do you feel more integrated? Yeah, I feel more integrated. They're all subjective quality of life measures. They never measure those things that they claim was the reason for having the surgery in the first place. Avoidance of suicide, avoidance of drug abuse, whatever it may be. They never measure those things afterwards, you see. So you have to understand, start to finish, it's cosmetic surgery. Because if you read a cosmetic surgery article, that's how they present their results. Quality of life survey. They don't come out and say, isn't that the most beautiful nose? Isn't that the most beautiful breasts you've ever seen? No, they come out and say, well, the patient feels better. Well, as I said before, they'll feel better for a while because that's what happens with body dysmorphic disorder. That's what happens with affirmation messaging with a child. They'll feel better. If you sprinkle pixie dust in their eyes to get them off to sleep, obviously it's a lie. You have no pixie dust, but the child feels better. Eventually they go, that pixie dust isn't working, right? I'm still in distress here. That's the nature. And that's also what you see in the arc of any particular person transitioning, is that affirmation messaging gets them hooked in. And when that particular message no longer works, they go on to the next step. Social transitioning of the child feels great until their body betrays them. Then the anxiety comes back. Puberty blockade feels great until their peers are grown and gone. Now the distress is back. Cross-sex hormones. Cross-sex hormones works great until it doesn't, because you can't urinate standing up, or whatever it may be. Then you come back, and they feel better at every step until they don't. And then you get to what the Swedish study showed us: 19 times higher suicide rate, 40 times higher in women, incarceration for violent crime, whatever it may be. Yeah.
And there's such unrealistic expectations moving in or going in terms of like function. I mean, I've spoken to young women who really think they're going to have between their legs what, men have, and it's going to work in the same way. And this is not true. And the same for men who get the bottom surgery.
Can we talk about that?
Oh, I think we should.
Plasty things. I do urge people who haven't looked them up, because I'm aghast that people are getting those awful phalloplasties.
Yeah. I've also been reassured that they're going to be much better in 10 years.
Sure. Yeah. Well, there's always technical problems that you can demonstrate. And so, for example, with phalloplasty, the use of local flaps versus free flaps, the use of sensate flaps versus non-sensate flaps, the inclusion.
Flap.
Okay. Yeah. Well, women seeking to present as men will, because of the testosterone, high levels, supernormal levels of testosterone that they're receiving, will develop some degree of clitoromegaly. The clitoris, of course, is the embryologic anlaga, the embryologic counterpart of the dorsum of the penis, right? That's what the clitoris is. And so the most commonly performed affirmation genital surgery in women seeking to present as men is a metoidioplasty. Metoidioplasty is where you lengthen the urethra along the underside of the now hypertrophic clitoris. So it's the use of flaps and grafts to lengthen the urethral tube out to the end of the clitoris to enable the person to urinate standing up. This is one of the very common life goals in women seeking to present as men, is to be able to walk into a men's room and urinate standing up. So metoidioplasty.
It has an acronym, STP, stand to pee. And
stand to pee. Not standard temperature and pressure, but stand to pee. Yeah. Yeah, so that's a very common operation. Well, let's look at the details of that. What's being done is the urethral opening in a woman is right at the base of the clitoris, and what you're doing is you're lengthening that urine tube out to the end of the hypertrophic clitoris. And you can do that with local flaps of skin, or you can do that with skin grafts, or a combination of both. You'll put a catheter in the construct, and they'll wear the catheter for a period of time. Then the catheter is removed, and the patient can then, urinate standing up. Here's the deal. Those skin flaps and skin grafts are sewn into place. There are suture lines there that not only create the tube, but attach the tube to the native urethra. Suture lines there. You have suture lines that exist in a wound field. That's a wound that has to heal. And it's a wound that has to heal initially with suture material in place. And you have a stream of urine that's going to be coming through that area. All such scars, no matter how good a plastic surgeon you are, you have scar effects that can stricture the urethra, or they can cause obstruction of the urethra, and because of obstruction, it can cause leakage through these suture tracts either at the connection point or along the construct. So you can very often wind up with urinary obstructions that require further surgery and urinary leakage that essentially causes a chronic repetitious soiling of the patient because they can't control their urine any longer. So it then constrains you to further surgery and reoperative surgery on the lower urinary tract. So this is a very common problem. When you go to the next level of what's called phalloplasty, now you're seeking to construct a counterfeit phallus using the patient's own tissues. So there, what you do is most common ones is using local flaps from the thigh. What is a flap? A flap is an area of skin and its blood supply, which you then lift from where it lives now, and you translate it to where the reconstruction is going to be, and you form it into a tube. So you have living tissue that's still connected to its blood supply that you can then form into a cylinder of flesh and make a phallus out of it. But in order to do that, you also have to have within that cylinder of flesh a urethra. So within the flap, you might include a skin graft that forms the lining of the urethra. Again, suture lines all over the place, suture lines everywhere, really, connected to the urethra. Whenever you lift and you translate tissue around, you run the risk of losing blood flow to it, compromised healing, possible loss of the flap. But that's another way to do a phalloplasty. A third and more technically advanced way is to do what's called a free flap operation, where you take tissue, the ideal tissue, right? Thigh tissue is not ideal because it's thick, the skin is thick, the phallus does not have thick skin on it. So you go someplace where you can get thin skin. And one of the most common places is the forearm. The forearm, very thin skin. And not only is it thin skin, but it has a named sensory nerve that runs right through it, the antebrachial cutaneous nerve of the forearm. So you can take the skin of the forearm with its blood supply and its nerve, take it completely free. Now it's over here on my back table. Now I am sewing it and cutting it in such a way as to make a cylinder of flesh with a skin lining within it. This is the most advanced way to do the operation, and technically challenging. But these are operations that I've done many of for reconstruction. So, for example, reconstructing a head neck wound from cancer treatment using a sensate radial forearm flap is a very common operation in advanced plastic surgery. But here's the thing to remember, is that you're beginning not with, in my case, I had a patient who had an IED injury to their genitalia, but I had to reconstruct with such flaps as I've just described. My introduction to the patient was a grievously wounded person in need of reconstruction, restoration of form and function. Find the tissue that matches, thin and pliant, sensate, all that stuff. That's reconstruction. But in the case of a phalloplasty, I begin with a patient who is whole, and my first move is to mutilate them. I castrate them. In the case of a man seeking to present as a woman, in the case of a woman seeking to present as a man, it's the same thing. Oophorectomy is castration, removal of the uterus, obliteration of the vagina. So the operation begins with a mutilating step. Now I'm reconstructing the harms that I've created, but I'm not restoring form and function. I'm creating an artifact. And not only am I creating an artifact, but I'm creating an artifact that is essentially non-functional, other than as a cosmetically appearing penis that conducts urine out of the bladder of the patient. Which is...
Get that. Do any of these, you've kind of described three, pseudo penises, for want of a better phrase, do any of them work functionally other than stand to pee? Do any of them work to have sex?
Well, yeah, if you take the phalloplasty construct, whether it be a local flap or free flap, you can put malleable implants. You can put inflatable implants within it so it can stimulate erection and facilitate penetration. But essentially, the sensation that structure has, best case, right? Radial forearm flap, antebrachial cutaneous nerve plugged into the ilioinguinal nerve of the groin. The best you can get out of that as far as sensation is protective sensation, meaning I won't catch it in my zipper and harm it, right? Or if I'm sitting on it, I'll know I'm sitting on it. right? Or if there's pressure on it, I'll know that I'm harming it. That's called protective sensation, right? That's the best you can hope for from such a.
So,
If I get that in a reconstructed patient, I go, this is a win. The patient can protect their reconstruction. But in the case of somebody who has come to me seeking fulfillment in a sexual, performative sexual identity, then the only erotic sensation that they're able to derive from that, first of all, contact with the phallic construct is going to feel like somebody's patting your thigh because I've plugged that nerve into the ilioinguinal nerve. And so whenever you touch that thing, they'll get protective sensation as if they're protecting their groin, right? The second thing is that operation for erotic sensibility relies on the fact that you are placing the native clitoris, you're protecting and preserving the native clitoris and positioning it at the base of this construct.
that's right.
Right?
So can they orgasm as a result? But their orgasm would be enlarged because of testosterone anyway.
Well, here's the deal. One of the axioms of plastic surgery is that when you manipulate sensate tissue around, if you preserve what was there to begin with, that's a victory, right? The idea that you're going to get improved erotic sensation from doing that clitoris preservation step is not the case, right? If you preserve sensation in the clitoris that's erotic sensation, that's a win. That's certainly a win. But if you go on the internet and you follow people who have taken you through their transition, and you go to those places where they congregate and speak about their results and things like that, very often what you find is that they're capable of orgasm, but they're the only ones capable of eliciting it in themselves. That very often their partners have difficulty with it. So essentially what you have is a form of masturbation that allows them to achieve an orgasm, but it typically doesn't come from intimate contact with another person because that other person can't seem to find the way to stimulate it because stimulation sensitivity has been degraded by the operation.
And what about the opposite, the vaginoplasty? Because I've heard so many men say they can orgasm after they've vaginoplasty. And I've always thought, how?
Yeah, I have too.
So tell us what the vaginoplasty.
Yeah, so in the case of a vaginoplasty, the historic operation was what's called a penile inversion vaginoplasty. And historically, this was the most commonly performed operation because the tissue you're using is conveniently located right in the surgical site already. And what is done is that the penis is filleted open, the erectile tissues are removed, the urethra is shortened, right? And what you're left with is the skin sleeve of the phallus. In order to preserve erotic sensation, what you preserve is sensation running along the dorsum of the penis, a nerve running along the dorsum of the penis to the glands. You have to preserve that strip of skin that contains that nerve, or isolate the nerve, which is a technically more difficult thing. And then you reduce the glands in size and create a neo-clitoris out of the thing, right? So whatever erotic sensation you're preserving by preserving sensation in the remnant of the glands.
Wow.
As we talked about before, when you do an operation, if you transpose tissue around, you're always degrading sensitivity, sensation, 2-point tactile discrimination, as we call it. So whatever erotic provocability is left there is left because of whatever they were able to preserve in this reduced glands that's now put there as a neo-clitoris. So that's at the base of that construct. Then that skin is inverted into the pelvis and placed between the bladder and the rectum, creating a neo-vagina. So you've got the skin of the penis has now become the lining of the counterfeit vagina. Well, that operation was the most commonly done operation, as I said before, because of proximity of the tissue you're going to use is right there already. But also because the majority of patients ever having that operation were men who persisted in cross-sex self-identification into adulthood. So you have sufficient tissue there to do the operation.
Mm-hmm.
The majority of patients now coming through are patients who have been puberty blockaded and cross-sex hormones, who have an absolute poverty of that tissue, right? And so that operation is less and less and less common now. And so, for example, the case of Jazz Jennings, and I mean, I think we were even invited into the consultation room when Jazz was talking to Marcy Bowers about the fact that Marcy couldn't do the penile inversion because he'd had puberty blockade. He had come there thinking this is the big change that's finally going to happen, and was dismissed from that because they couldn't do a penile inversion. Well, what are the alternatives? Well, the most commonly done alternative now is to use a loop of bowel to be the counterfeit vagina. So a segment of the lower intestinal tract is transposed down into the pelvis to serve as the receptive sleeve for the counterfeit vagina.
And is it true that it smells, or is that a myth?
That's a myth. Well, I mean, here's the thing to understand about it, is that it may smell depending upon levels of hygiene. So it is in the nature of the lining tissue of the gut to produce mucosal secretions, right? Mucus secretions are part of the protective process immunologically and mechanically that the bowel has. The vagina has similar secretory epithelium there, but it's a different kind of secretion aimed at protecting from a different kind of life. Right, the lining of the vagina is suited to protection from the mechanical effects of copulation. The colon has no such protective function, right? And so the mechanical trauma of copulation with the rectum these are known things in surgery. I've treated many patients who have injured themselves grievously through, anal intercourse and things like that. Well, essentially what you're doing is you're creating a similar structure in a natal male to have a counterfeit vagina.
Wow.
Well, what are the complications that you can get into from that? In the first operation, as I said, you've placed external skin within the warm, moist environment of the pelvis. It's skin that doesn't want to maintain its dimensions because it no longer has erectile tissue around it. So it wants to shrink up. Furthermore, it has suture lines in there where you've taken that sleeve that you opened and you've sewn it closed into a cylinder. There's suture lines along there. And you've placed this structure up in the pelvis. On one side is the bladder. On the other side is the rectum. If you have wound healing problems, and you wouldn't know because you can't see it, you've tucked it into their pelvis. If you have wound healing problems and the wound breaks down, it can develop communications between the counterfeit vagina and the bladder. Now you have uncontrolled urinary leakage. Or the counterfeit vagina and the rectum. Now you have feces coming through the construct, right? That's a similar risk even when you do the colon interposition, because again, you've got this construct with suture lines laying right next to bladder and bowel, right? So reoperation for such problems as urinary fistulas, what are called enterocutaneous fistulas, cystocutaneous fistulas, these reoperations are common and well described in the literature. And as the patient population has grown, the number of reported cases has grown. And
I might have lost track, but did I hear right? Feces can be coming out of the neo-vagina, the construct.
That's correct. It's called an neovaginal fistula, communication between a hollow organ in the abdomen and the outside world. Fistula. Yeah, I'm sorry.
No, keep going.
The fistula is commonly developed where you have obstructions or foreign material, like suture lines, right? Yeah.
Wow.
Another thing, and before we leave the subject of potential complications, I'm sorry to overwhelm you with this information, but another common problem that is being recognized more and more now is that in the setting of high levels of sex hormones, the risk of cancer transformation goes up measurably, significantly. And if you have chronic wounds in and of themselves have a risk of malignant transformation. But chronic wounds in the setting of high levels of sex steroids, measurably increased risk, and cancer developing in areas that are inaccessible other than with scanning and close follow-up and things like that. So
what you just described is applicable to both men and women. There's an increased cancer rate. Okay.
And am I right in thinking, like, I think, for vaginoplasty, it's a 70% rate of complication, or phalloplasty, it's 80%. Like, it's very high complication rates for these, very difficult, to the point of almost impossible surgeries.
Yeah, they're not impossible surgeries, and reported complication rates. It's very important to examine the data presented as to what they're considering a complication. So, a return to the operating room, for example, for a hematoma, that's a complication, but it's a very common complication in major surgery.
Okay.
Yeah, so in any particular study, you want to look at the details. But for example, the complication rate of the urinary fistula or urinary obstruction is probably some number less than 10% for that particular complication. But it's a known and measurable complication, and that's one of the complications you're weighing against, benefits and harms, kind of things like that. Well, have we demonstrated any benefit from the operation yet? No. We're just going to have to put that on the list of known harms, aren't we? In addition to castration and genital mutilation and all the rest of it.
I have to say, like, working with detransitioners, and I do a lot of group work with detransitioners, and those that have genital surgery, there is a kind of a pause of the road back is so long and complicated once you've had genital surgery. It feels like it's a different flavor than those who haven't had genital surgery. There does feel like a difference between them. And I agree. I think it would be very hard to come back from. So there should be some sort of recognition of that. But I'm meeting so many women with mastectomies. I would like you to speak a little bit about that as well. Also, I see you use the word mutilation freely, and I know a lot of detransitioners don't like that word. Have you thoughts on this? Do you just think this is a technical word that needs to be said? I don't language police. I'm just interested in language.
Well, what is mutilation? Mutilation is the destruction of form with its associated loss of function. That's a mutilation. So an IED is a mutilating event. The removal of a upper air digestive tract cancer results in a mutilation of the head and neck, right? Regardless of how you arrive at that result, mutilation is the destruction of form and function by whatever means that might have happened, right? Yeah, and so it's an unfortunate word to have to use in some settings, and of course, when you're talking about the pastoral care of somebody who has suffered these things, you want to be careful. But I think when we're talking about the use of professional language for the evaluation of diagnoses and outcomes, it's a very important word to use, because when you're talking about a patient who arrived in the operating room who was whole, and now an hour into the operation has lost form and function, there's no doubt in my military mind that a mutilating event has occurred.
Sometimes they're losing functions that they don't even have never experienced. Like kids who've never had an orgasm lose the possibility to orgasm. And if you try to talk to them about it, you're talking about something they've never experienced.
Never.
And you can't just say, believe me, they feel really, really, really good. You don't want to lose this.
Yeah, and so I think one of the most poignant moments in that whole jazz arc of horrors is Marcy Bowers, who I think did much of his operations. She publicly said that the patients who have had puberty blockade and cross-sex hormones, it is completely removed any possibility of erotic provocability and orgasm. Well, one of the things to understand, of course, and you probably know well, I'm certain you know well, is that one of the effects of puberty blockade is its effects on not only higher executive functioning of the brain, but also the emotional sexual integration of the brain into the wholeness of the person that makes them capable of the emotional bonding that's required for the successful procreation and raising of a child, right? That's utterly been shut off. Yeah. And so Marcy Bowers publicly confessed that. Yeah. And in fact, when Jazz in one of her shows was being questioned about who is she attracted to, who is he attracted to, she basically shrugged shoulders and said, I just love everybody. Right. The questioner was going for content about their sexual orientation, and all they got was a shrug of the shoulders. To your point, that's one of the effects of puberty blockade.
Yeah. Key point, because these are chemically medicalized experimental adults, because they haven't gone through puberty. They have had their puberty blocked, and then they're going into a chemical experimental existence, but it's not puberty that they go through. So Jazz hasn't gone through puberty, and therefore is a chemically created medical adult who hasn't gone through puberty. This has never happened before. We're creating something that has never happened. And so, what is the adult who hasn't gone through adolescence and hasn't gone through puberty? We are now finding out. And as you said, Dr. Lappert, this is a childlike brain who I fancy. I like everybody. I don't like a 10-year-old. I like everybody. I do want to ask a little bit about mastectomies, but before you finish, but I do want to say about Marcy Bowers. Marcy Bowers, trans woman, born male, fathered 3 children, and playing fast and loose with Jazz Jennings, who'd never had an orgasm, who'd never had puberty, who it felt so profoundly inappropriate. They argued on the surgeon's table. The 2 surgeons were arguing about which direction to go on the surgical disaster that was unfolding on the table, and there was Jazz, a kid who'd been led down a garden path. It's an extraordinary story, that whole Jazz Jennings debacle.
Yeah.
Yeah.
Yeah, and the presentation of that story to juries is going to be, it's going to be significant. Yeah, it's going to be significant.
Before you go, tell us a little bit about mastectomies. I've noticed among the detransitioners I've worked with that some of them are finding it very hard to get a reconstruction, because effectively something along the lines of, when you have a mastectomy for gender reasons, it seems to be difficult to get the reconstruction back afterwards if you're a detransitioner. Do you know anything about this? Or?
Well, I can tell you that surgeons, as a general rule, are very leery of reversing other surgeons' cosmetic operations, right? Because they fear what we talked about earlier, that this is a body dysmorphic person, that now I'm offering the next cosmetic operation to them, and they're going to be hating me a year from now and that sort of thing. So it can be a real impediment, mostly because of a lack of understanding on the part of the surgeon. But as far as the technical aspects of reconstructing a young woman who has had bilateral mastectomy, there's nothing particularly complicated about it. It's a very standard operation, because essentially the surgical field of reconstruction is better than what we typically find in breast cancer reconstruction. The tissue is younger, it hasn't been radiated, they haven't had chemo, all kinds of things that make it a more suitable patient, either for autologous reconstruction with their own tissue or reconstruction with tissue expanders and implants. So it's the operation is the same, and improvements on that operation using free grafts of fat and things like that have really improved the outcomes. So I think that impediments to reconstruction, because now it is a reconstructive operation, impediments to reconstruction right now are, I think, primarily fear on the part of surgeons, concern on the part of insurance agencies, hospital institutions who want nothing to do with the patient because of, their involvement in
previous. Just to back a little bit on that, the detransitioners, I know they're not doctors and I'm not a doctor, but they're saying things like, because I got masculinizing surgery, there's nothing for the surgeon to work with as a reconstruction. While if I'd had,
that's not true. That's not true. So what is the result of chest masculinization? First of all, it's complete mastectomy, typically with what we call relatively robust flaps of skin. Because it's not an operation for cancer, the removal of the breast isn't as fastidious in getting every last little bit of breast tissue out of there, trying to prevent cancer, right? This is a cosmetic operation, so the skin flaps tend to be a little bit more robust, a little bit more elastic, more fat underneath them, so they're actually better for the reconstruction. What do you have? You have a transverse scars on the chest, which you use the existing scars, you raise the flaps of skin up. You can put a tissue expander in there, which is an implant that you gradually inflate over time. Skin under stretch grows. That's how women carry pregnancies. You're doing the same thing on the chest. You're expanding the tissue expander until you have sufficient skin for the breast mound. You take the tissue expanders out. You put the permanent implants in. And then at some point you create a nipple. If they lost their nipple, they probably still have their nipple as a full thickness graft. Most of them do. So that stage of the reconstruction is fairly simple. So that's a very simple operation.
Why are they
patient
so,
surgery?
Why are they
patient
so
surgery.
bad? I've seen so many mastectomies online, so many, because a trans man can't keep his top on for longer than 10 seconds as far as I can see. So they're all pretty awful. But I've seen so many though, and I have to say they're not a credit to your industry. They look awful, the mastectomy.
Sure.
The scars of the nipples look all wrong. It all looks really bad.
Yeah, it's I've seen some of those. I've seen some good and some bad. I think it's because a lot of people have gotten into the business who don't have a long history in plastic surgery. So, I mean, if I was to look at my mastectomies from when I was a junior resident in general surgery compared to the ones I did in my last couple of years of practice, I'd see much better results in my more recent operations. So you probably have a lot of sort of junior guys getting into the business because, let's face it, mastectomy is a simple operation. I mean, it is a simple operation. And so if you're in a surgical practice that had a senior gender affirmation surgeon and you were the junior guy on board, odds are you're getting that case and he's getting the phalloplasty.
Wow.
Or whatever. Yeah. So difficulties like scar can be overcome. One of the difficulties with chest masculinization is that the two scars meet very close to the midline, and pre-sternal scars that are right over the breastbone, tend to do badly, tend to be visible. And so that can be a problem. But as I tell all of my patients that I did breast cancer reconstruction on, our goal is not for you to look perfect naked. The goal is that you can get up in the morning and regardless of what you have planned for the day, regardless of what you're going to wear, whether it's a business suit, a cocktail dress, or a bathing suit, you don't have to worry about what you're going to look like. You're not going to look perfect naked, but to the average person, you're going to look whole and you're going to feel whole. That's the goal. Yeah.
No, you can restore something of the form, but you can't restore any of the function. These women can't nurse afterwards, and I imagine they might lose a little bit of that erotic sensation that the nipples often have for people.
Actually, you lose all of the erotic sensibility from the nipple because the most commonly performed chest masculinization operation involves not only removal of the breast, but removal of the breast and the nipple. And then the nipple is taken off the front of the breast on the back table. Now you take the nipple off the front of the breast and you prepare it as a full thickness skin graft. Having closed the chest wound, you now create a territory for that skin graft to be applied. And so now you have a full thickness skin graft that looks like a nipple. Here's the deal. The nipple is an unusual territory of skin because it has a named nerve that provides sensation. It's called the fourth intercostal nerve, meaning the fourth nerve that runs between the ribs. The fourth intercostal nerve has a privileged route into the hypothalamus of your brain, right, where it stimulates your adenohypophysis to produce oxytocin. Milk letdown factors used to be called oxytocin. And that's the reason why stimulation of the nipple, first of all, causes the brain to produce oxytocin, which causes the breast to produce the milk. But also that oxytocin effect is what results in erotic provocability and perhaps more importantly, the sense of bonding that the woman gets with the child that she's holding in her arms or her husband whom she's holding in her arms. That's one of the effects of the sensitivity of the nipple because of that connection to the brain. That's irretrievable. That's irretrievably lost.
Wow.
That's devastating. Well, thank you, Dr. Lappert. You're going to be speaking at our conference in Albuquerque, New Mexico, and we can't wait because I think I don't hear very much. Are you the same, Brett? We don't hear this particular side of trans as often as maybe we should.
No, no, we don't. And this has been super informative. And I've been cringing the whole time too. Like when you describe some of these operations, something in me just like retracts. It's just so icky.
It was very interesting. You retracted when Dr. Lappert was talking about vaginoplasties, and I retracted when he was talking about phalloplasty. So clearly it was personal.
Yeah.
It was like just a response to yourself.
Yeah.
Wow.
Well, thank you.
Yeah, thank you so much.
It's been a pleasure, and I look forward to Albuquerque. And
It was great. You got to come
All right.
too.
Very good.